Hello everyone, my name is Dr. Ahmed Abd. I'm a lecturer of urology. My subspecialty is pediatric urology. Today we will be discussing acute scrotal conditions. Acute scrotum means acute scrotal pain, and in order to know the medical conditions that can cause acute scrotum, we have to discuss briefly the anatomy and contents of the scrotum. Of course, the most important structure in the scrotum is the testis, and of course, there is the male duct system that starts with the epididymis and the vas. The testis is supplied by the testicular arteries arising from the abdominal aorta and drained by the pempiniform plexus of veins. The testes are covered by the tunica vaginalis, the spermatic fascia, and scrotal skin. The most important three clinical conditions that can cause acute scrotum are acute testicular torsion, also known as spermatic cord torsion, torsion of the testicular appendages, and epididymitis or acute epididymoorchitis. There are other causes of acute scrotum, maybe are less common or less important than the three conditions that we mentioned earlier, and other causes of acute scrotum include acute testicular trauma, complicated hernias or hydrocele, complicated varicocele, complicated testicular tumors, and sometimes acute scrotal vein can be referred from other sites like in patients with renal colic and some other abdominal conditions. Now we will focus on the most three important causes of acute scrotum, which are acute testicular torsion, torsion of the testicular appendages, and acute epididymitis or acute epididymoorchitis. In fact, the most serious cause of acute scrotum is acute testicular torsion. This is a true urologic emergency. So we need first to understand what is torsion. Torsion means that the organ is twisted, and when the testis is twisted, the blood supply to the testis is interrupted. And if this twist is not relieved, then the condition may end up with testicular loss. That's why this condition should be diagnosed and treated in a timely fashion. Acute testicular torsion should be always suspected in any boy or any male presenting with acute scrotal pain, and if the diagnosis of testicular torsion is established, emergent scrotal exploration is necessary to save the testis. Testicular torsion has a bimodal age distribution. It is seen more commonly in adolescent boys between the age of 11 and 16 years old, and also seen in the perinatal period. In fact, the type of torsion that occurs in the adolescent age group is called intravaginal torsion, while that perinatal or neonatal type is called extravaginal torsion. So what is intravaginal and what is extravaginal torsion? This is the normal testicular anatomy. The testis, as I mentioned, is covered by the tunica vaginalis that has two layers, and the tunica vaginalis covers the testis anteriorly and laterally only. The tunica vaginalis does not extend to cover the posterior aspect of the testis. And as you know, the testis is supplied by the testicular artery and drained by the pempiniform plexus of veins. Intravaginal torsion, it happens when there is abnormal covering of the tunica vaginalis. The tunica vaginalis cover the testis anteriorly, laterally, as well as posteriorly, and it extends high to invest the lower part of the spermatic cord. And in case of intravaginal torsion, the testis twist inside the tunica vaginalis. That's why it's called intravaginal torsion. The other type of torsion is called extravaginal torsion, and the twist of the testicular vessels occurs outside the tunica vaginalis, and this is more commonly seen in the perinatal age group. So the Bell-Claver deformity is the predisposing anomaly for intravaginal torsion. Again, it is caused by abnormal covering of the testis. This is what is normal. The tunica vaginalis is covering the testis anteriorly and laterally, but not posteriorly. But in case of Bell-Claver deformity, the tunica vaginalis extend all around the testis and extend to involve even the lower part of the spermatic cord, and that's why the testis is freely hanging inside the tunica vaginalis like the clubber of a bell. And that deformity is most commonly seen bilaterally. So how testicular torsion presents? As we mentioned, testicular torsion is the most important cause or the most serious cause of acute scrotal pain. The patient presents with sudden onset of scrotal pain. The pain is sharp, and the patient usually describes the pain as the most or the worst pain he has ever had in his life. Sometimes pain is referred to the lower abdomen. It is commonly associated with nausea and vomiting. And on examination, the testis is swollen, red, and tender because the spermatic cord is twisted. The testis is seen high riding in the scrotum, and sometimes it is transversely lying. And one of the characteristic signs of testicular torsion is absence of the cremasteric reflex. This is very pathognomonic for acute testicular torsion. And the cremasteric reflex is simply that striking or scratching the medial aspect of the thigh leads to contraction of the cremasteric muscles that surrounds the testicle and subsequently lead to elevation of the testicle. Acute testicular torsion is in fact a clinical diagnosis. The diagnosis is established by the patient presentation and the clinical examination. The most commonly performed investigation for acute testicular torsion is scrotal duplex ultrasound, but scrotal duplex should not delay surgical intervention because time factor is crucial in the case of testicular torsion, and longer wait time may lead to testicular loss. This is the normal scrotal duplex ultrasound. This is the testis here, and as you can see, this red and blue patches indicate the normal testicular blood flow. In case of acute testicular torsion, the blood flow to the testis is interrupted, and therefore there is no color flow waves here in the testis, and the testicular blood flow is absent, while the blood flow to the parietus is still preserved. Sometimes we order urine analysis to differentiate testicular torsion from acute epididymoorchitis, and in case of acute testicular torsion, urine analysis is normal, while in case of acute epididymitis, the urine analysis shows signs of urinary tract infection. So the most important message if you are confronted with a male presenting with sudden and severe testicular pain, don't mess about it. Ask the patient to go immediately to the doctor because time factor is crucial in case of testicular torsion. any delay can lead to testicular loss. Acute testicular torsion is a true surgical emergency. The treatment is immediate surgical exploration, and during scrotal exploration, the affected testis is exposed. The testis is untwisted, and the viability of testis is checked. If the testis is found to be viable, orchiopexy is done, meaning that the testis is fixed or tacked to the scrotum to prevent recurrence of the twist. And as I mentioned earlier, acute testicular torsion is predisposed by the bell-clapper deformity, which is commonly seen bilaterally. That's why orchiopexy should be done on the contralateral side as well. But if the testis was found to be necrotic on exploration, then it is removed. And do not forget, orchiopexy should still be done on the contralateral side. Always keep in mind that time is your enemy in case of testicular torsion. The longer you wait, the less likely that you would be able to save the testicle. If orchiopexy is done within 6 hours of the onset of symptoms, it is highly likely that you would preserve the testicle. However, if the intervention is delayed beyond 24 hours, almost always the testis is lost. All other causes of acute scrotum is considered in the differential diagnosis of testicular torsion. Among these causes is torsion of the testicular appendages. Testicular appendages are embryologic remnants of the paramesonephric duct. They are located in relation to the upper pole of the testicle. Sometimes the pedicle of these testicular appendages is twisted, and the blood supply of these appendages is interrupted. These appendages do not have known function, so this condition is not serious, but it is sometimes confused with acute testicular torsion. In case of torsion of the testicular appendages, pain and tenderness are localized to the upper pole of the testis. The testis is normal, has normal vertical orientation. The cremasteric reflex is preserved, and the blue dot sign is a characteristic sign of testicular torsion. You would see bluish discoloration in relation to the upper pole of the testis, and if scrotal ultrasound is done to differentiate from acute testicular torsion, you would see the blood flow to the testicle is preserved. Testicular torsion of the testicular appendages is treated conservatively with supportive measures with non-steroidal anti-inflammatory drugs to relieve pain and inflammation. And if the condition is confused with acute testicular torsion, scrotal exploration sometimes is performed just to rule out acute testicular torsion. This is a picture of a boy with a torsion of the testicular appendages. This is the blue dot sign. You can see there is bluish discoloration in relation to the upper pole of the testis. This is the normal anatomic location of the testicular appendages, and here is the picture on scrotal exploration. You can see the testis is looking normally, and the blood flow to the testicle is preserved, while this is the testicular appendages. It is ischemic and its pedicle is twisted. This is the scrotal duplex in case of torsion of the testicular appendages. There is heterogeneous mass related to the upper pole of the testicle, and on duplex ultrasound you can see that the blood flow to the testicle is preserved while the testicular appendages is avascular. Acute epidermitis is another important differential diagnosis of acute scrotum. It is commonly seen in post-pubertal and sexually active males. The condition presents with scrotal pain, but the onset of pain is more insidious. Testicular torsion or torsion of the testicular appendages. Usually the pain builds up over days. The condition is predisposed by urinary tract infection or urethritis or sexually transmitted disease. That's why it is usually preceded by urinary symptoms like frequency, urgency, dysuria, or urethral discharge. And on examination, there is progressive scrotal swelling involving the whole testicle. Usually starts posteriorly, and it commonly involves the contralateral testes as well. The epididymis is engorged and tenderness, and the cremasteric reflex is preserved, and the testis has normal vertical orientation, and elevation of the testis characteristically leads to improvement or relief of this testicular pain. The diagnosis is confirmed by urine analysis that shows signs of urinary tract infection, and if a scrotal ultrasound is performed, the blood flow to the testis and epididymis is increased as a sign of inflammation. This table differentiates testicular torsion from acute epididymitis. Again, testicular torsion has bimodal age distribution. It is seen in peripubertal or peripubertal boys or in the neonatal age group. Acute epididymitis that is predisposed by urinary tract infection or sexually transmitted disease is seen in post-pubertal and sexually active males. Acute testicular torsion has sudden or acute onset, while the onset is more insidious with acute epididymitis. In testicular torsion, the pain is short and is associated with nausea and vomiting. In acute epididymitis, there is fever and usually preceded with dysuria or urethral discharge. On examination, the testis is transversely lying and high riding in testicular torsion, while it has normal vertical orientation with acute epididymitis. Elevation of the scrotum relieves the pain in case of acute epididymitis, but not in the case of testicular torsion. The cremasteric reflex is lost in testicular torsion while it's preserved in acute epididymitis. Urine analysis is positive for urinary tract infection in case of acute epididymitis. The blood flow to the testis is absent in testicular torsion while it is increased with acute epididymitis. The treatment of testicular torsion is immediate surgical exploration with orchiopexy or orchiectomy and contralateral orchiopexy, while in acute epididymitis the treatment is antibiotics and non-steroidal anti-inflammatory to relieve the symptoms and inflammation. Now we will talk briefly about Fournier gangrene as one of the acute scrotal conditions. As you have studied in pathology, gangrene means necrosis with superadded infection. Fournier gangrene is severe necrotizing infection affecting the male genitalia and perineum. Idiopathic gangrene of the scrotum, streptococcal scrotal gangrene, spontaneous fulminant gangrene of the scrotum or perineal phlegmon are all synonymous for Fournier gangrene, but Fournier gangrene is the most commonly used name. Fournier gangrene is predisposed by diabetes mellitus, local trauma to the perineum or scrotum, genital surgery, urinary extravasation, perianal or perirectal infection. And the infection is usually polymicrobial, caused by aerobic organisms like E. coli, Klebsiella, and Enterococci, as well as anaerobic bacteria such as bacteroides, anaerobic streptococci, and the Clostridium species. Fournier's gangrene is characterized by scrotal swelling, redness, and tenderness in a predisposed patient with history of trauma, surgery, urethral obstruction with urinary extravasation, or a patient with history of perianal infection. The pain is excruciating. The patient is usually toxic with high-grade fever, tachycardia, tachypnea, and sometimes the consciousness is impaired. On examination, the scrotum is swollen with dark purple spots that gradually progress to extensive gangrene, and on palpation there is crepitus due to gas formation by gas-forming organisms. And on the lab investigation, the patient is anemic, hypocalcemic because of deposition of calcium in the gangrenous tissue, and on plain X-ray or scrotal ultrasound, air can be clearly seen in the scrotum and lower abdominal wall. This is a picture of a patient with Fournier gangrene. The diagnosis of Fournier gangrene is critical, and the treatment is immediate debridement and to remove the necrotic tissue, and sometimes repeat debridement is required in 24 to 48 hours if there is question about the adequacy of initial debridement. The debridement is combined with antibiotics, and the antibiotics should be broad spectrum and also include cover for anaerobic bacteria. Urinary diversion is required in case of urinary extravasation, and fecal diversion is required in case of perianal infection. Orchiectomy is almost never required in case of Fournier gangrene because the testes receive separate blood supply from the testicular vessels arising from the aorta, while the scrotum and spermatic coverings are supplied by the pudendal arteries arising from the external iliac and femoral vessels. Later on, after the infection is cleared, reconstruction might be required. Now we will discuss briefly genital trauma. It is more commonly seen in males for clear reasons because of the difference in the genital anatomy between males and females. The majority of genital trauma is blunt, and while only 20% are caused by penetrating injuries. Blunt scrotal trauma may result in testicular dislocation, hematocele, which is blood collection in the tunica vaginalis. It may also lead to testicular rupture or scrotal hematoma. Dislocation of the testicle is actually rare and is treated by manual replacement of the testis and the secondary orthopexy. And if manual repositioning is not successful, then the condition requires immediate surgical exploration with orchiopexy. Hematocele also can be a result of blunt scrotal trauma and is usually treated conservatively, especially if smaller than 3 times the size of the contralateral testis, while if hematocele is large, more than 3 times the size of the contralateral testis, or expanding, it requires surgical exploration. If testicular rupture is suspected, the scrotum should be immediately explored. Any clots or necrotic tissue should be removed, and then the tunica vaginalis should be repaired. Penetrating scrotal trauma is relatively rare, seen in only 1/5 of cases, and surgical exploration is the rule, and on exploration, the treatment of the non-viable tissue is performed, and in most of cases, primary reconstruction of the testis and scrotum can be successfully performed, and if the testis is severely damaged, orchiectomy might be necessary. Thank you so much. I hope you find this lecture helpful.